keep safe the adults, teachers, parents, grandparents with whom they come in contact. Dr. Hahn, will there be treatments or medicines this fall that will help speed the recovery from COVID-19 or reduce the possibility of death? I believe the fear of going back to school or going anywhere these days is in large part because of the fear of severe illness or even death. If that risk can be lessened by new treatments, it should increase confidence in going back to school. I'd also like to commend Dr. Hahn and the work the FDA did to get tests on the market quickly as possible to help understand the spread of the virus. Since then, FDA has worked out which tests have not worked as well as they should and taken steps to remove them from the market. That's what's supposed to happen in the urgency of a pandemic. Admiral Giroir, at our last hearing, you said you expected there to be 40 to 50 million diagnostic tests available each month by September. Is that still true? And exactly, how does the school district go about making sure it gets those tests? And who pays for them? What are the prospects from the Shark Tank at the National Institutes of Health that there will be new, reliable, and inexpensive tests so we can have even more widespread testing? And Dr. Redfield, you're continuing to work on updated guidelines about going back to school and college safely. And are CDC employees going to be available in our states to help work with school districts to develop their plans? And what advice do you have about the arrival of the flu season this fall at the same time as COVID-19? This is a lot to discuss, but there will be time during the next 2.5 hours to answer most of those questions. Let me quickly highlight 3 areas that have come up in our 4 earlier hearings this month that I think need clarification. First, on contact tracing. No doubt contact tracing is crucially important. It identifies the people who might have been exposed so that they don't in turn expose someone else. According to an NPR report on June 18, states have already hired at least 37,000 contact tracers. State officials and Johns Hopkins Center for Health Security issued a report estimating the need for as many as 100,000 contact tracers. Several reports suggested Congress appropriate money to pay for those tracers. The reality is Congress already has. On April 24th, Congress appropriated $11 billion, which has been sent to states and tribes for the expenses of testing. That legislation explicitly said the money could be used for contact tracing. This is in addition to $755 million from the first emergency appropriations legislation on March 6 that could be used for contact tracing. And that's in addition to the March 27 legislation in which Congress appropriated $150 billion, $1.5 billion in the CARES Act for states, territories, and tribes to use for COVID preparedness and response. The CARES Act also included the $150 billion to states, but a significant amount of that $150 billion has not been spent, even though it is all designated for expenses related to COVID-19, which include contact tracing. For example, Tennessee's governor has told me he's reserving as much as $1 billion of that so that he can determine what flexibility he has in spending the money. Washington State has not spent as much as $1.2 billion. Missouri State Treasurer says they've not spent about $1 billion. According to the report by state health officials in Johns Hopkins, an average salary for a contact tracer would be a little more than $35,000. This adds up to about $3.5 billion for 100,000 contact tracers. So the point is, Congress has already sent to states plenty of money to hire all the contact tracers that are needed. Second, who pays for the testing? In the CARES Act, Congress voted to make all COVID-19 tests available to patients at no cost. This meant insurers would cover diagnostic tests, which detect whether a person is currently infected with the virus, and also antibody tests, which indicate whether a person has had COVID-19 in the past and now may have some protection in the future. Guidance from the Labor Department, Treasury Department, and Centers for Medicare and Medicaid Services said last week that insurers are only required to pay for tests without patient cost sharing if a doctor orders it. I agree with that. But given that the CDC specifically recommends doctors' orders tests in two situations, when a person has signs or symptoms of COVID-19 or recently had contact with someone known or suspected to have COVID-19 who pays for the testing at other times. I believe Congress will need to take action to further clarify who pays for the testing at other times. For example, a school may want to do random testing. Perhaps it should make an arrangement with the state to pay for that. Or perhaps Congress needs to provide more money to pay for that. If an automaker wants to test all of its employees at the plant every 2 weeks, perhaps the automaker should pay for that. Or perhaps the state would want to pay for that. That needs to be clarified. Finally, flu shots. CDC has said more people need to get flu shots this fall so healthcare workers can better distinguish between COVID-19 and the flu. CDC says a priority is for all children over the age of 6 months to be vaccinated for the flu so they don't become sick and pass it to more vulnerable populations who could have more severe consequences. On January 24th, Senator Murray and I hosted our first bipartisan briefing on coronavirus at a time when there were only 4 cases in the United States. Since then, this committee has had 4 more briefings. Today is our 8th hearing on coronavirus and U.S. preparedness. Last week's hearing was about steps to take this year while our eye is on the ball to better prepare for the next pandemic. I've issued a white paper outlining 5 recommendations for Congress to prepare Americans for the next pandemic. And that paper has received more than 350 substantive comments that are available to all members of the committee. After all senators have had a chance to ask their questions, I will conclude the hearing by asking our witnesses if they have 2 or 3 suggestions about steps Congress should take this year to deal with the next pandemic, most of which will also help with this one. But this hearing is about what happens now as administrators prepare to reopen schools and colleges. Experts underestimated this dangerous and sneaky virus, and there is still much we don't know about it. But we do know the basic steps to take to reopen schools and colleges in 2020 before there is a vaccine, and those are these: social distance, wear a mask, wash your hands, test, contact trace, and isolate those exposed or sick. And hopefully by the fall, there will be treatments to make the consequences of the disease less severe. I look forward to hearing from our distinguished witnesses how school leaders and college presidents can safely reopen 135,000 schools and 6,000 colleges, and also learning the latest developments on testing and treatments that we can expect during the year 2020 before vaccines arrive. Senator Murray.
Well, thank you very much, Mr. Chairman. Thank you to all of our witnesses for joining us here today. And of course, thank you to our staff for setting up the technology so we can hold this hearing safely. I want to get to the point quickly, and I'm going to be blunt about it. The COVID-19 response in our country is still a disaster. 126,000 lives lost was once considered an estimate on the high end of the spectrum. But the year is just halfway over, and it is now a grim reality. We have lost more Americans to COVID-19 than we lose to the flu each year, than we lost to the opioid crisis last year, and more lives than we've lost in every American war except the Civil War and World War II. And despite what President Trump claims, this pandemic is not fading, far from it. Several states are seeing rapid, record-setting increases, and the country just saw its largest single-day increase to date. And while this public health crisis rages across the country, we've seen the leadership crisis raging in the White House. As the president proves, time after time, he cares less about how this pandemic is impacting families and communities and more about how it makes him look. Just consider his appalling continued failure on testing. President Trump said anyone that wants a test can get a test. They still can't. He said testing was overrated. It is not. He said we prevailed on testing. We have not. Now he's saying we should be doing fewer tests and testing makes us look bad. Well, it clearly does not, and we clearly need to be doing more. The most honest thing he has said about testing is that he doesn't take responsibility at all. And that is exactly the problem. It's why Congress actually took bipartisan action in the last COVID-19 response bill to require the Trump administration to submit a comprehensive national testing plan. And it's why I'm still pushing for this administration to include more details in that plan and take more steps to ramp up testing. Because we are still nowhere close to the testing and tracing capacity we need to safely reopen our country, and ending support for federal testing sites while sitting on billions in testing funds Congress provided is not going to get us there. The ongoing struggle to get President Trump to take testing seriously should be a stark warning to Congress that when it comes to vaccines, we can't just leave this administration to its own devices. We have to hold it accountable. We know this pandemic will not end until we have a vaccine that is safe and effective, that can be widely produced and equitably distributed, and that is free and accessible to everyone, which is why we need a comprehensive national vaccine plan from the Trump administration as soon as possible. Given the testing plan, which Congress only received after forcing the administration's hand, was too little, too late. We need to take the opportunity we have right now to get a vaccine plan much earlier and avoid the missteps we've seen with testing. So I hope Republicans will work with me in a bipartisan way once again to require this administration to put forward a plan. We need the Trump administration to show us how they will ensure a vaccine is safe and is effective. I'm as eager as anyone for a vaccine, but this isn't just about doing something fast. It is about doing it right. That's why we need to know the process for developing a vaccine is rigorous, it's inclusive, it's transparent, and it is science-driven. But in light of the hydroxychloroquine debacle and the removal of Dr. Bright from BARDA for questioning the administration's efforts to promote that unproven treatment, we cannot take for granted this process will be free of political influence. We have to demand serious oversight. In order to give the public full confidence that a vaccine is safe and effective, the administration needs to commit now to being fully transparent about the standards a vaccine will be expected to meet and releasing the clinical trial data that FDA uses to evaluate safety and effectiveness. We also need a plan detailing how to produce and distribute vaccines nationwide and make sure everyone can actually get them. We saw with testing how avoidable bottlenecks create damaging delays when the federal government refuses to step in and lead like it needs to do in a time of crisis. And unfortunately, we saw how existing health disparities are exacerbated without a plan to overcome them, as even the incomplete data we currently have shows Black, Latino, and tribal communities have significantly less access to testing than white communities. This is an injustice that we must not repeat when it comes to vaccines. We also need a plan to guarantee vaccines are free so that cost is not a barrier for patients. And it's worth noting we still need to act to make COVID-19 treatment available at no cost too. And the plan must address barriers like vaccine hesitancy and misinformation, especially when one of the most prominent sources of misinformation so far has been the President of the United States. While the discovery of an eventual vaccine may still be far off, these are issues we need the administration to answer now. So I hope Republicans will work with me to require the administration to submit a comprehensive vaccine plan and address many of the other urgent issues stemming from this pandemic. our businesses, our workers, teachers, students, and families do not have what they need to safely return to work or school, period. Our medical system, doctors, nurses, frontline workers continue to face unimaginable risk, stress, and fatigue. They need Congress to step up to help them continue to save lives. And families need us to continue to ensure they have basic services and can keep food on their tables. The House passed the HEROES Act 46 days ago to get more relief to frontline workers, to families, and businesses. It is well past time for Leader McConnell and Senate Republicans to sit down with fellow Democrats and get to work. There's no question our country is still in crisis. And every day the Senate fails to take action is a day we allow it to get worse. I also hope, Mr. Chairman, that we will be able to have another hearing on this crisis soon with administration officials whose testimony is long overdue. Secretary Azar, Secretary DeVos, and Secretary Scalia. Thank you, Mr. Chairman. I look forward to our witnesses today testimony and the questions that we have for them.
Thank you, Senator Murray. We'd ask each witness now to summarize his testimony in 5 minutes. Pleased to welcome our witnesses. Each of you are making significant contributions to our government's response to COVID-19, helping us go safely back to school, back to work. We're grateful for your service to our country. Our first witness is Dr. Anthony Fauci. He's director of the National Institute of Allergy and Infectious Diseases at the National Institute of Health. He's held this position since 1984. He's led the agency's research related to HIV/AIDS, influenza, malaria, Ebola, and other infectious diseases. He's advised 6 presidents on domestic and global health issues. He's one of the principal architects of the Emergency Plan for AIDS Relief. In 2014, he was involved in treating Ebola patients at NIH and worked on vaccine trials for Ebola. Next, Dr. Robert Redfield, Director of the U.S. Center for Disease Control and Prevention, CDC. For more than 30 years, he's been involved with clinical research related to chronic human viral infections and infectious diseases, especially HIV. He was founding director of the Department of Retroviral Research within the U.S. military's HIV research program and retired after 20 years of service with the U.S. Army Medical Corps. Third, Admiral Brett Giroir. Admiral Giroir is the Assistant Secretary for Health at the U.S. Department of Health and Human Services. He oversees the development of the department's public health policy recommendations. Specific to COVID-19 response, Admiral Giroir has taken on testing and focused on increasing the number of tests we can do with existing technology. His federal service includes directing the Defense Sciences Office of the Defense Advanced Research Projects Agency and a variety of other important responsibilities. Finally, we will hear from Dr. Stephen Hahn. Dr. Hahn is Commissioner of the U.S. Food and Drug Administration, the FDA. Before joining FDA, he held leadership positions as Chief Medical Executive at the University of Texas MD Anderson Cancer Center and is chair of the Department of Radiation Oncology at the University of Pennsylvania. Early in his career, he was senior investigator at the National Cancer Institute at the National Institutes of Health. He's been commander of the U.S. Public Health Service Commission Corps in 2005. We welcome our witnesses. Dr. Fauci, welcome. Let's begin with you.
Thank you very much, Mr. Chairman, Ranking Member Murray, members of the committee. Thank you for giving me the opportunity to discuss briefly with you today the role of the National Institutes of Health in research addressing COVID-19. And as you indicated, Mr. Chairman, I will, during the question period and alluding to in the presentation, address some of the issues regarding schools. The NIAID-NIH Strategic Plan for COVID research involves 4 major components. The first is to improve the fundamental knowledge of understanding of the biology of the virus and the immune response to the virus in order to better inform us in the development of diagnostics, therapeutics, and vaccines. Some of the work that has come out of that program right now informs very greatly how we will address vaccine development, particularly understanding the conformation of the components of the virus that induce an appropriate immune response. In addition, we will develop and are developing animal models. Apropos of what you mentioned about children in school, we have a program called HEROES, which is Human Epidemiology and Response to SARS coronavirus, which is determining the incidence and transmissibility among children, a very important issue when you talk about opening schools and the impact that might have. In addition, the development of diagnostics, point-of-care, sensitive and specific diagnostics under the RADx program, including the RADx Up for underserved populations. Third, to characterize and test therapeutics. You mentioned the importance of this as we open up schools. There are a number of programs very active that have already shown efficacy or not in some drugs, as well as a number of clinical trials that are ongoing. One in particular was the first randomized placebo-controlled trial showing that the drug remdesivir diminishes by about 32% the time it takes to get to recovery in people with advanced disease, pulmonary involvement. In addition, we have another study combining this with an anti-inflammatory agent. Next, we have vaccines. As several have mentioned, it's extremely important to have safe and effective vaccines available for everyone in this country, as well as globally. In that regard, we put together, myself and some of my colleagues, and published in Science magazine a few weeks ago, what we call a strategic approach to coronavirus 19 vaccine research and development. It's not a comprehensive plan about every aspect of vaccine, but it is a strong plan regarding the research and development pathway. And what we have done in this is that we have what's called a harmonized effect, because we know there are many vaccines that are in trial now at various stages. And what we did, and the federal government, thanks to the generosity of the Congress, has put a considerable amount of money in order to harmonize the trials of multiple candidates from different companies, so that we have common endpoints, common data and safety monitoring board, and common immunological parameters that are being funded and are being pursued. In addition, there are a number of different platforms that are being pursued so that we don't have all our eggs in one basket. As you know, one of those is right now getting ready as we approach next month of going into phase 3 trials, and others will be staggered along the way in the middle of the summer, end of the summer, early on. There is no guarantee, and anyone who's been involved in vaccinology will tell you, that we will have a safe and effective vaccine. But we are cautiously optimistic, looking at animal data and the early preliminary data, that we will at least know the extent of efficacy sometime in the winter and early part of next year. Again, working with the companies and the investment made by this Congress, hopefully there will be doses available by the beginning of next year. These are the things that we feel aspirationally hopeful about, and we will continue to pursue this. I'll stop there, Mr. Chairman, and be happy to answer questions later. Thank you.
Thank you, Dr. Fauci. Dr. Redfield, welcome.
Good morning, Chairman Alexander, Ranking Member Murray, and distinguished members of the committee. I want to thank you for the opportunity to testify before you today with my HHS colleagues. The COVID-19 pandemic is the most significant global public health challenge that we have faced as a nation in more than a century. In the United States, daily cases are increasing after an extended decline. We're seeing significant increases in the southeast and southwest regions of this nation. The number of jurisdictions in upward trajectory has continued to increase. Now 29 of 55 jurisdictions fall into this category. The evidence tells us that these cases are driven by many factors, to include increased testing, community transmission, and outbreaks in the settings such as nursing homes and occupational settings. Hospitalizations now are going up in 12 states, and as of this weekend, daily death now has increased in the state of Arizona. CDC is closely monitoring these increases and have 48 teams with more than 140 staff currently deployed in 20 states and 2 territories. CDC is providing technical expertise to the health departments in epidemiology, contact tracing, infection prevention and control, and communication. Beyond providing this critical boots on the ground, CDC is working with your states and community in other ways. CDC is speaking with the states, tribal, local, and territorial health departments on a daily basis to develop strategies to stop COVID while reopening businesses and schools. The initial guidance for institutes of higher learning was shared in March, and the K-12 setting was shared in February. Both these guidances have been updated since and over the past several months. As more information becomes available, we'll continue to disseminate that more broadly. CDC released consolidated recommendations for COVID testing, including interim testing guidelines for nursing homes, as well as testing options for high-density critical infrastructure workplaces after a COVID case is identified. Testing guidance for higher education in K through 12. Higher education should be posted today, and K through 12 later this week. These recommendations are consistent with previously published testing guidelines and are meant to supplement, not replace, the guidance of local jurisdictions. CDC continues to advance science around the COVID-19 impact in certain populations and those who are at heightened risk for severe outcomes. Our most recent analysis of the United States case data from the pandemic, hospitalizations were 6 times higher and death 12 times higher among those with reportedly underlying conditions compared to those who did not have these conditions. We've expanded the list of underlying conditions where the evidence is clear that they put people at higher risk of severe illness. These conditions include chronic kidney disease, COPD, having a weakened immune system from a solid organ transplant, obesity, serious heart disease, sickle cell disease, and type 2 diabetes. Our analysis also provides further evidence that racial and ethnic populations are disproportionately affected by this epidemic. While data is the backbone of this response, containing the outbreak depends on 4 core interventions: readily available testing, comprehensive contact tracing, timely isolation of known cases, and quarantine to break the transmission. We are not defenseless against this disease. We have powerful tools at our disposal: social distancing, wear a face cover in public, and be disciplined about the frequent hand washing. It is critical that we all take the personal responsibility to slow the transmission of COVID-19 and embrace the universal use of face coverings. Specifically, I'm addressing the younger members of our society, the millennials and the Generation Zs. I ask those that are listening to spread the word. Before I close, I'd like to speak briefly about how CDC is assisting the front lines of our health departments to fight COVID. With your support, CDC has awarded $12 billion to 64 jurisdictions. Data modernization is underway. Public health laboratories are building resilience. Number of contact tracers have grown 345%. The disease impacts us all, and it's going to take all of us working together to stop it. Together, I believe we can achieve the possible. Thank you, and I look forward to your questions.
Thank you, Dr. Redfield. Admiral Giroir, welcome.
Chairman Alexander, Ranking Member Murray, and distinguished members of the committee, it's good to see all of you again. First, I want to clarify my current role. On March 12th, Secretary Azar requested that I lead the coordination of COVID-19 testing efforts within the department. To be clear, although I am assuming some of my traditional duties as the Assistant Secretary, I am maintaining my role coordinating testing, including now the NIH RADx diagnostics program, along with Dr. Collins, to assure that innovations are immediately translated into practice. In order to get back safely to work and school, the overarching, most critical, and essential action we must first accomplish is to control the virus, meaning rapidly extinguishing any outbreaks and minimizing community transmission. All of us are concerned about recent data from several states indicating rising infections and now an uptick in hospitalizations and deaths, even as other states and the majority of counties are maintaining a low infection burden. Knowing what we know now about asymptomatic transmission and the fact that we are in a much better position today in terms of our mitigation strategies, PPE, and testing, we can reverse these concerning trends if we work together. First, we must take personal responsibility and be disciplined about our own behavior. Maintain physical distancing. Wear a face covering whenever you can't physically distance. Wash your hands. Stay at home if you feel sick. If you have been in close contact with someone infected or in a gathering without appropriate precautions, get tested. Shield the elderly and the vulnerable of any age. And follow the guidelines for opening up America again. The criteria are very specific and are as relevant today as when we released them. In addition, this week, we are initiating surge testing in multiple communities of highest concern in coordination with state and local officials. Now back to schools and businesses. As Dr. Redfield stated, the CDC will release recommendations on K-12, institutions of higher education, and general business reopening. These will include considerations for integrating testing, especially surveillance testing, into a comprehensive strategy. As you asked me, Mr. Chairman, if you are a superintendent of a school system or a president of a university, number one, apply the CDC guidelines in consultation with your state and local public health officials so that testing is a part of your comprehensive plan, which should also include prevention and clear mechanisms to isolate positive students. Number two, assure your testing needs are incorporated into your state testing plans. As we outlined in the National Testing Strategy, each state has developed and will continue to build upon a customized state testing plan developed in full coordination with the federal government. The next iteration, covering July to December, is due on July 10th. These state plans drive the allocation of certain scarce resources. For example, in May and June, the federal government has distributed nearly 26 million collection swabs and over 19 million tubes of transport media. HHS also prioritizes allocation of certain key laboratory tests, like point-of-care tests, according to state-specific needs. There are also strategies particularly relevant to surveillance testing, especially in universities and businesses. For example, pooling of samples, meaning combining 2 or more samples, and possibly up to 10, into a single test, makes sense where the prevalence of infection is low. And such pooled surveillance testing can be conducted in a university research lab outside of a CLIA environment. But if a pooled sample is positive for COVID, every individual in that pool would need to be tested through a health system. I would like to close by recognizing my fellow officers in the United States Public Health Service Commission Corps, the uniformed service that I lead. 4,536 officers have deployed to support the pandemic response, exemplifying the care and compassion that all of us feel for those who have suffered during this pandemic. I thank each and every one of these officers and their families, and on their behalf, sincerely thank all of you in Congress for supporting our training needs and establishment of a Ready Reserve Corps to supplement our ranks during inevitable future national emergencies. Thank you for the opportunity to provide these remarks.
Thank you. Thank you, Admiral Giroir. Welcome, Dr. Hahn.
Thank you, Chairman Alexander, Ranking Member Murray, and members of the Health Committee. I appreciate very much the support that you all have provided for our efforts during this time of COVID-19. FDA has a vital role in the federal government's response to the pandemic. One of our core missions is to advance the public health by helping to speed medical products that are safe and effective. We have provided appropriate regulatory flexibilities to assure that the American public has access to critical medical products and safe food, and confidence that our decisions are based on medicine and science. Since the public health emergency was declared, FDA has issued more than 100 emergency use authorizations for diagnostic tests, personal protective equipment, ventilators, other devices, and drug products. And we have issued more than 50 guidance documents to ensure the continuity of healthcare in the food supply. I am pleased to announce that today, FDA is taking action to aid the timely development of a safe and effective vaccine to prevent COVID-19 by providing guidance for developers with recommendations on the data needed to facilitate manufacturing, clinical development, and approval. We recognize the urgent need to develop a safe and effective vaccine to prevent COVID-19, and we want to work collaboratively with industry, researchers, and other partners to accelerate these efforts. While the FDA is committed to help expedite this work, we will not cut corners in our decision-making, and we are making clear in our guidance what are the data that we need that should be submitted to meet our regulatory standards of approval. This is particularly as important as we know that some people are skeptical of vaccine development efforts. The FDA strongly encourages the inclusion of diverse populations in all phases of clinical development, including populations most affected by COVID-19, and specifically racial and ethnic minorities, as well as adequate representation in late-phase trials of elderly individuals and those with medical comorbidities. We also have information in this guidance about including women who are pregnant, as well as for pediatric assessments of safety and effectiveness. The American people should know that we have not lost sight of our responsibility to maintain our regulatory independence and ensure that our decisions related to all medical products, including COVID-19 vaccines, are based on sound science and the available data. This is a commitment the American public can have confidence in and that I will continue to uphold personally. While vaccine research is ongoing, rapid testing and therapeutic development can aid in the safe return to school, college, and the workplace. FDA is constantly evaluating new data we receive on testing so that we can promote the development of new and better tests and remove tests that are not reliable from the market. And we have put into place an initiative to accelerate the development of treatments called the Coronavirus Treatment Acceleration Program, or CTAP. We've seen some of the consequences of that program, such as the authorization of remdesivir and the recent information regarding other therapeutics that might be of benefit to patients with COVID-19. We are working day and night to provide guidance to and review proposals from companies, scientists, and researchers who are developing therapies for COVID-19. We are now preparing for the next phase of addressing this evolving crisis. It is mission critical that the agency constantly evaluate whether our processes are maximal to promote and protect the public health. And therefore, we are beginning a comprehensive real-time review and assessment of our actions to date to address the COVID-19 pandemic, and I'm glad to answer questions about that review. I want to thank the more than 17,000 FDA employees who have been working night and day to help expedite medical products, but also to provide the necessary oversight with the appropriate science and data. We know that the virus remains with us. FDA is committed to doing the critical work that will get the country to the point at which Americans judge it safe to return to work and school as quickly as possible. I am incredibly proud of the dedicated women and men of the FDA whose commitment to defeating this pandemic has been unwavering. I can assure you the FDA will continue to provide leadership, expertise, guidance, and information as we continue to address this unprecedented challenge and fulfill our mission to protect and promote public health. Thank you, and appreciate and look forward to your questions.
Thank you, Dr. Hahn, and thanks to each of our witnesses. We'll now begin a round of 5-minute questions. All of the senators are participating today, almost all, and so I would ask the senators and the witnesses to try to keep each segment within 5 minutes. Dr. Fauci, assume I'm superintendent of one of 14,000 school districts, and in our community, we understand that there are health risks for children going back to school, but we've concluded that the risks to their education, mental health, and social development is a greater risk if they don't go back to school. So what would your advice be to a school superintendent about what he or she should be thinking about as children go back to school in a few weeks to keep them safe?
Thank you for that question, Mr. Chairman. It is an important question, but I think we need to point out that it really will depend on the dynamics of the outbreak in the particular location where the school is. And one of the things we want to emphasize and have been emphasizing is to take a look at where you are in the particular area of the so-called opening America again. Are you at the gateway, phase 1, phase 2, phase 3? The CDC has guidelines about the opening of schools at various stages of those checkpoints. The basic fundamental goal would be, as you possibly can, to get the children back to school and to use the public health efforts as a tool to help get children back to school. Let me explain what I mean. In other words, if we adhere to guidelines of what we've heard in many of these presentations you just heard about the physical distancing in the community, the use of masks, things like that, that will help to keep the level of infection in the community down, which will then make it easier to get the children back to school. If you are in an area where you have a certain amount of infection dynamics, there are things that can creatively be done about modifying things like the school schedule, alternate days, morning versus evening, allowing under certain circumstances online virtual lessons. Those are the kind of things that we need to consider, but also importantly, always make the goal that it is very important to get the children back to school for the unintended negative consequences that occur when we keep them out of school.
Thank you, Dr. Fauci. Dr. Redfield, one of the concerns would be that children who generally speaking haven't been damaged nearly as much as adults, particularly elderly adults, by this virus, might carry the virus to their teachers, administrators, or parents or grandparents at home. It seems to me that the availability of treatments this fall, medicine for the environments that reduce the risk of sickness and death, could be very important in increasing confidence in going back to school. You mentioned some of those in your testimony. Are there others? What will the availability of treatments be this fall? And specifically, what about so-called antibody cocktails of the kind that were developed for Ebola and approved by the FDA?
Well, I think that'd be a great question also for Dr. Fauci. I'm going to make a small statement. He may want to add to it. Clearly, we do have remdesivir, as he mentioned. We have now evidence that steroids can improve therapy. And as you mentioned, we have convalescent plasma that Steve Hahn could comment on, that's using the antibodies from individuals that have gotten better from COVID that are currently under evaluation and potentially be available.
Since I have just a minute, Dr. Redfield, let me go to Dr. Hahn and let him answer that question too. Thank you.
As I mentioned, remdesivir has been authorized based on its reduction in hospitalization days. The steroids were mentioned. Convalescent plasma, we have evaluated the safety through a large expanded access program at the Mayo Clinic, and it's been found to be safe in over 20,000 patients who administered it. We are waiting for the safety data, and we will be passing those data along to BARDA, who's the sponsor of that program. I think that antibody data will help us in terms of the development of monoclonal antibodies. We have a number of sponsors who've come in for monoclonal antibody studies. We are already well into that treatment. Monoclonal antibodies are synthetic antibodies that will provide, that the theory is will provide protection against the infection of the virus. And we're hopeful that those studies by the late summer, early fall will provide us information about their effectiveness and safety.
So you're optimistic that there will be more than one treatment available this fall for teachers, administrators, older adults?
Yes, sir, I'm optimistic.
Thank you very much, Senator Murray.
Thank you very much to all of our witnesses. We all very much appreciate your service and your work. Dr. Fauci, last time you testified before this committee, you warned us of needless suffering and death if states begin reopening too early. And just over a month later now, we are seeing a record number of cases. We do not have enough tests and we do not have enough contact tracers. And just yesterday, CDC's Dr. Schuchat said we have too much virus to control in the US, arguing, and I quote, "This is really the beginning." Our strategy hasn't worked. I wanted to ask you, what do the federal government and the more than 30 states with rising case numbers need to do to reverse this trend?
Thank you very much for that question, Senator Murray. I am also quite concerned about what we are seeing evolve right now in several of the states. As you know, in 4 of the states, in Florida, Texas, California, and Arizona, more than 50% of the new infections are in those areas where we're seeing surges. The things we need to do, I think you alluded to in your question to me, we've got to make sure that when states start to try and open again, they need to follow the guidelines that have been very carefully laid out with regard to checkpoints. What we've seen in several states are different iterations of that, perhaps maybe in some going too quickly and skipping over some of the checkpoints. But even in states in which the leadership, in the form of the governors and the mayors, did it right with the right recommendations, what we saw visually in clips and in photographs of individuals in the community doing an all or none phenomenon, which is dangerous. And by all or none, I mean either be locked down or open up in a way where you see people at bars not wearing masks, not avoiding crowds, not paying attention to physical distancing. I think we need to emphasize the responsibility that we have both as individuals and as part of a societal effort to end the epidemic, that we all have to play a part in that. And I think if you look at the visuals, what we saw were a lot of people who maybe felt that because they think they are invulnerable, and we know many young people are not because they're getting serious disease, that therefore they're getting infected has nothing at all to do with anyone else, when in fact it does. Because if a person gets infected, they may not be symptomatic, but they could pass it to someone else, who passes it to someone else, who then makes someone's grandmother, grandfather, sick uncle, or a leukemic child on chemotherapy get sick and die. We've got to get that message out that we are all in this together. And if we are going to contain this, we've got to contain it together.
Well, I assume that would mean that elected and community leaders need to model good public health behavior and wear a mask.
We recommend masks for everyone on the outside. Anyone who comes into contact in a crowded area, you should avoid crowds where possible. And when you're outside and not have the capability of maintaining distance, you should wear a mask at all times. Thank you.
Dr. Redfield, last week, Dr. Julie Gerberding, who served as the CDC director under President George W. Bush, testified to our committee that if she were in charge, one of her top priorities would be the creation of a national vaccine plan that addresses the science, development, allocation, uptake, and monitoring of a vaccine, saying, quote, "We know this is in our future and we are not ready for it." I couldn't agree more. And that plan has to detail how the federal government will scale up manufacturing, coordinate the supply chain so we avoid the missteps we saw with testing. It needs to combat misinformation and vaccine hesitancy and make sure that vaccine distribution addresses health disparities and a lot more. Dr. Redfield, do you agree a plan like that is needed?
Senator, I think it's very important that we have an integrated plan for this vaccine.
When can we expect to see one?
Well, I'm going to ask Dr. Hahn if he'd like to comment. I know recently they had a vaccine plan for, at least for the FDA's perspective. CDC is working on the issues that you said that I think are so important in building vaccine confidence in this
Can you tell
country.
me the CDC will be giving us their plan since CDC would be writing the comprehensive plan?
We're developing a plan as we speak, and again, to keep building on the efforts that we have to rebuild what I call vaccine confidence in this country, which is really critical. And then on top of that, there'll be a very defined plan for distribution of this vaccine, prioritization of this vaccine, monitoring for safety of this vaccine.
A couple weeks, a couple months, the end of the year. Do you have any estimate on when we'll see that plan?
Well, it's currently in development within the group. And I'd anticipate that we'll see that plan in the near weeks ahead, Senator.
Weeks, not days, months?
In the weeks
You're-
ahead, it's a collective effort that we're doing together within the concept of Operation Warp Speed. But CDC's been working on this plan literally for probably the last 10 to 12 weeks.
Well, Mr. Chairman, I would just say we need to see that plan. We need to know what it is. The American public needs to know what that is. Communities need to know what that is. So I hope that we urge that plan to be public as soon as possible so we all know what to expect.
Thank you, Senator.
Senator Murray. Senator Burr.
Thank you, Mr. Chairman. After working on pandemic policy now for 17 years, I'm reminded this morning Tony Fauci's been doing it twice as long as I have, and most of you at the dais have been doing that as well. I urge my colleagues, pay attention to what each of these individuals say, because some things are predictable up here. Congress is a full-fledged partner and funds things when there's an urgent need, a threat that's out there. And I know, Tony, you've seen over the years when there's not that threat out there, things get shelved, like platforms that we could have developed and have better countermeasures today, platforms that then could address vaccines at a much faster pace than maybe what we're doing. But we spend more time with the blame game than we do with focuses on how the future should look. While all of us, members of Congress and people within government, wish that we could get back to normalcy, your agencies and members of Congress are also charged with making sure that we map the future so that future generations have better protections than what we have. And that's why I applaud the chairman for his white paper, and I would encourage every member of that dais to be brutally honest with us about where changes need to be made and where they don't need to be made. Dr. Redfield, I think you would agree with me that testing and surveillance on this has not been the best performance by CDC. I don't want to dwell on where we've come up short. Share with these members and myself, what can we expect over the next several months from CDC that will be different than what the past has looked like?
Well, thank you, Senator, for your question. I think CDC will continue to work with the state, local, tribal, territorial health departments to build their capacity. I think we all know that for decades, there's been consistent underinvestment in public health in this nation. And the core capabilities to do that job, data monitorization, predictive data analysis, laboratory resilience, workforce, very appreciative for the emergency response fund that Congress provided. These are critical infrastructure issues that the reality are have been underinvested. CDC is right now probably providing 50 to 70% of all public health funding to each state. We need to have a much more robust investment in these core capabilities. What you are going to see because of the Congress acting, CDC has provided now $12 billion to the local, state, territorial, tribal health departments to begin to build that core capability that we would have liked to build over the last several decades so that there's enhanced testing. As has been mentioned, it's complicated here because this virus is so asymptomatic for so many, so the traditional methods of diagnosis, contact tracing, isolation are going to be inhibited for many individuals, and that's going to require broader community-based surveillance strategies. Those plans, as was mentioned by the Admiral, we've received them for June and July. We're working with the local jurisdictions. They're going to have them in middle July for the plans for the rest of the year. And we're going to be working side by side with them to continue to augment the public health capacity to respond to this COVID virus with basically enhanced surveillance and enhanced early diagnosis, contact tracing, isolation to begin to bring this outbreak under control.
I hope some of that money will be used to upgrade the systems at CDC that are antiquated.
Sir, I agree with you there. I mean, I think as those of you know, when I was given the opportunity to do this job, very early on, within a month, I recognized that the core capabilities of our public health infrastructure is not there, particularly the one that I know you've been very supportive of, data monitorization, predictive data analysis. And that is in progress. It can't happen too soon. And we're appreciative of the support that Congress has given, and I do think it's fundamentally critical to bring our data system, and as you know, the data personnel that we have, and we thank you for your efforts there. And as we need to hire those individuals strategically, we will continue to do that to make sure that the premier public health agency in this country has the personnel and data systems that it does need. But I will say the other big issue we have to correct is to make sure our public health, state, local, territorial, and tribal have that integrated health system of data.
Dr. Hahn, I think you have used your authorities under PAPA at FDA in a very effective way. And the FDA has risen to the challenge during the public health emergency, cutting red tape and maintaining the agency's gold standard for review of life-saving medical products. You've specifically mentioned innovative clinical trial designs and the use of real-world data as areas where the FDA has gained ground during the response to COVID. How do you plan to ensure that this progress is maintained long after the coronavirus response is over?
Thank you, Senator Burr. Critical issues that you bring up. In addition, some of the things that we're doing on the review side to actually expedite review and work with innovators and developers, we will continue. Part of our review of our actions to date, so a mid-action review, will inform how we move forward. No question the fact that real-world evidence and modernization of our data systems are needed, particularly around supply chain, and demand for medical products, but also on the review cycle and the innovative clinical design trials, as you mentioned.
Thank you for that. Mr. Chairman, I do hope that you or another member will allow Dr. Fauci at some point today to make any comments on the reports that there's a new swine flu that the Chinese have apparently identified and how that might affect us in the future in this country.
Well, Dr. Fauci, why don't you do that now if you have anything to say about a swine flu?
The Chinese, over the last week or two, have identified a virus in the environment. It has not yet shown to be infecting humans, but it is exhibiting what we call reassortment capabilities. In other words, when you get a brand new virus that turns out to be a pandemic virus, it's either due to mutations and or the reassortment or exchanges of genes. And they're seeing virus in swine, in pigs now, that have characteristics of the 2009 H1N1, of the original 1918, which many of our flu viruses have remnants of that in it, as well as segments from other hosts like swine. When they all mix up together and they contain some of the elements that might make them susceptible to being transmitted to humans, you always have the possibility that you might have another swine flu type outbreak as we had in 2009. It's something that still is in the stage of examination. It's not so-called an immediate threat where you're seeing infections, but it's something we need to keep our eye out on, just the way we did in 2009 with the emergence of the swine flu. It's called G4 is the name of it.
Thank you. Senator Sanders.
Thank you very much, Mr. Chairman, and let me thank all of our panelists for being here and for the great work that they are doing on this pandemic. Let me ask a question that has just bothered me lately. All of you, and I think most Americans, understand how important social distancing is. We're told over and over again, the chairman told us at the beginning of this meeting, stay apart, at least 6 feet apart if you can. And just the other day, however, American Airlines announced that they were going to fill up all of their planes. And other airlines have done the same. So you're going to have people going from New York to California, 5-6 hours, sitting inches apart from each other. And then you got buses all over America where people are kind of packed in like sardines. My question is, why hasn't the government, whether it's the CDC or the Department of Transportation, issued guidelines prohibiting those violations of what we all know to be common sense? Who wants to, Dr. Fauci, you want to start on that one there?
Thank you, Senator. Well, I'm not the CDC, but I'd be happy to make a comment on that, and maybe Bob would also. I mean, obviously, that is something that is of concern. I'm not sure exactly what went into that decision-making. I would hope there would be something to mitigate against that, because I know, as we've said, and I continue to repeat it, that avoiding crowds, staying distance, and when in a situation like that, wear a mask. I think in the confines of an airplane, that becomes even more problematic.
But generally, I understand the mask thing, but doesn't it sound a little bit silly and a little bit in violation of everything you guys have been talking about? To have people sitting next to each other for 5 or 6 hours in an airplane or crowded into a bus. And my question is, why hasn't, the president issues a lot of executive orders? Why haven't we stopped that type of activity and told the airlines and bus companies that is unhealthy?
Senator, I appreciate your question, and I think it's a critical area. I can tell you that when they announced that the other day, obviously there was substantial disappointment with American Airlines. A number of the airlines had decided to keep the middle seat thing. I can say this is under critical review right now by us at CDC. We don't think it's the right message, as you pointed out. Again, we think it's really important in individuals that are in, whether it's a bus or a train or a plane, or social distancing to the degree that's feasible, and at least have a reliable face covering. So,
Okay. Well, I thank you, and I just hope very much that the CDC or the appropriate agency basically tells these companies that that is unacceptable behavior. They're endangering the lives of the American people. Let me go to another question. I just have a few more questions, and not a lot of time, so I'd appreciate brief answers. At the University of Washington, the Institute of Health there indicated that if 95% of the American people were to wear masks, we could save some 30,000 lives. A number of countries, including South Korea, France, Turkey, and Austria, have provided low-cost or free masks to all of their people, something that I believe in. Would you support an effort to greatly increase the production of high-quality masks in this country and distribute them free of charge to every household in America? Dr.
Yes.
Fauci or anybody else wants to jump in on that?
Yes, of course. I think masks are extremely important, and we keep hammering home. And I think what you just mentioned is as important. There's no doubt that wearing masks protects you and gets you to be protected. So it's people protecting each other. Anything that furthers the use of masks, whether it's giving out free masks or any other mechanism, I am thoroughly in favor of.
and I just want to echo that, Senator, in my opening statement. I called on an environment that we have universal masks. I think it's fundamentally the most important thing we can do.
That's great. But when you refer to quote unquote universal masks, which I agree with you on, would you be supporting the increased production of high quality masks and basically distributing free of charge to every household in America? Because I think that's going to save tens of thousands of lives. Would you agree?
So Senator Sanders, this is Brett Giroir. Yes, sir, I agree that is very important because we need to support mask wearing. I would also point out that Dr. Cadillac, the Asper, has contracted for hundreds of millions of cloth face coverings that could be distributed around the country, and those kinds of processes are being thought of. When I'm not in uniform, I wear them. They're white. They work very effective, and I think they're a great investment for the American people.
Good, thank you. My very last question, it's an issue I've raised now for the last couple of months. All of us hope to God that a good, safe vaccine will be developed as soon as possible. But that vaccine may not mean anything to a low-income person who might not be able to afford it. I happen to believe that we should make these vaccines. And by the way, as you all know, federal government, our tax dollars are going to the tune of billions of dollars into drug companies to help develop this vaccine. That's okay. But would you agree with me that after that kind of investment, we should make sure that every American, every person in this country can get a vaccine regardless of their income?
Yes.
Okay. Anybody else want to comment on that?
Yes, Senator. Agreed.
Yes, Senator.
Yes, Senator.
Well, good. Thank you all very much.
Thank you, Senator Sanders. Senator Paul.
Thank you. Fatal conceit is the concept that central planning with decision-making concentrated in a few hands can never fully grasp the millions of complex individual interactions occurring simultaneously in the marketplace. It is a fatal conceit to believe any one person or small group of people has the knowledge necessary to direct an economy or dictate public health behavior. I think government health experts during this pandemic need to show caution in their prognostications. It's important to realize that if society meekly submits to an expert and that expert is wrong, a great deal of harm may occur when we allow one man's policy or one group of small men and women to be foisted on an entire nation. Take, for example, government experts who continue to call for schools and daycare to stay closed, or that recommend restrictions that make it impossible for a school to function. For a time, there may not have been enough information about coronavirus in children, but now there is. There are examples from all across the United States and the world that show that young children rarely spread the virus. Let's start in Europe. 22 countries have reopened their schools and have seen no discernible increases in cases. These graphs behind me show no surge when schools open. The red line is where the schools opened. There is data from Austria, Belgium, Denmark, France, Germany, Netherlands. No spike when schools are opened. Contact tracing studies in China, Iceland, Britain, and the Netherlands failed to find a single case of child-to-adult infection. Here at home, child care for essential workers continued to be available in some states throughout the pandemic. Brown University researchers collected data on daycares that remained open during the pandemic. Over 25,000 kids in their study found that only 0.16% got COVID. And when you looked at the confirmed cases for staff, there was about 1% of more than 9,000 staff. The YMCA also has put forward statistics. 40,000 kids at 1,100 sites. There were no reports of coronavirus outbreaks or clusters. Dr. Joshua Sharfstein of Johns Hopkins writes, there is converging evidence that the coronavirus doesn't transmit among children like the flu, that it is a lower risk. Just yesterday, the American Academy of Pediatrics says we got to get kids back in school. We want them physically present in school. They even cite mounting evidence that children are less likely to contract the virus. Ultimately, this all comes down to the fatal conceit that central planners have enough knowledge somehow to tell a nation of 330 million people what they can and can't do. Perhaps our planners might think twice before they weigh in on every subject. Perhaps our government experts might hold their tongue before expressing the opinion whether we can play NFL football or Major League Baseball. Not in October. Perhaps our experts might think twice before telling the whole world that a COVID vaccine likely won't provide herd immunity. We don't know. Why weigh in with these opinions that we have no knowledge of? These are forecasts that may well be wrong. Perhaps our experts might consider the undue fear they are instilling in teachers who are now afraid to go back to work. No one knows the answers to these questions. We shouldn't presume that a group of experts somehow knows what's best for everyone. Hayek had it right. Only decentralized power and decision-making based on millions of individualized situations can arrive at what risks and behaviors each individual should choose. That's what America was founded on. Not a herd with a couple of people in Washington all telling us what to do and we like sheep blindly follow. This all begs the question, when are we going to tell the people the truth? That it's okay to take their kids back to school? Dr. Fauci, every day, virtually every day, we seem to hear from you things we can't do. But when you're asked, can we go back to school? I don't hear much certitude at all. I hear, well, maybe it depends. All of this body of evidence about schools around the world shows there's no surge. All of the evidence shows that it's rare. I mean, we've so politicized this and made it politically correct that the WHO releases that it's rare, and you have a scientist up there honestly giving her opinion. What happens to her? She's blackballed, and her report that she refers to is taken off the website. When you go to that scientist's speech and you try to click on the link, the WHO has now screened it from us because it said something that's not politically correct. That, guess what? It's rare for kids to transmit this. But I hear nothing of that coming from you. All I hear, Dr. Fauci, is we can't do this, we can't do that, we can't play baseball. Well, even that's not based on the science. I mean, flu season peaks in February. We don't know that COVID's going to be like the flu season. It might, but we don't know that. But we wouldn't ban school in October. You might close some schools when they get the flu. We need to not be so presumptuous that we know everything. But my question to you is, can't you give us a little bit more on schools that we can get back to school, that there's a great deal of evidence, and it's actually good evidence that kids aren't transmitting this. It's rare, and that kids are staying healthy, and that, yes, we can open our schools.
Mr. Chairman, do I have a little bit of time to?
Well, I give you a little that was
answer
well
that.
over 5 minutes, but we'll.
Thank you,
Go
Senator
ahead and
Paul.
please answer the question.
Yeah, so very quickly, Senator Paul, I agree with a lot of what you say about, this idea about people having to put their opinions out without data. And sometimes you have to make extrapolations because you're in a position where you need to at least give some sort of recommendation. But if you were listening, and I think you were, to my opening statement and my response to one of the questions, I feel very strongly we need to do whatever we can to get the children back to school. So I think we are in lock agreement with that. The other thing that I'd like to clarify very briefly is that when things get in the press of what I supposedly said, I didn't say. I never said we can't play a certain sport. What happens is that people in the sport industry, they could either be people from Players Association, owners, people involved in the health of the players, ask me opinions regarding certain facts about the spread of the virus, what the dynamics are. I give it, and then it gets interpreted that I'm saying you can't play this sport or you can't play that sport. I agree with you. I am completely unqualified to tell you whether you can play a sport or not. The only thing that I can do is, to the best of my ability, give you the facts and the evidence associated with I know about this outbreak. Thank you.
Thank you. We just need
Paul.
more optimism. There
Thank you,
is
Senator
good
Paul.
news out
We'll
there.
now
We're
go to
not
Senator
getting it.
Casey.
Mr. Chairman, thank you very much for the hearing, and I want to thank our witnesses for their public service. Mr. Chairman, let me start with Dr. Hahn, then I'll move to Admiral Giroir. Dr. Hahn, I wanted to ask you about vaccines, and as your testimony indicates, and as we've been discussing over time, as researchers work to develop vaccines to protect against COVID-19, it's important that the final FDA-approved products have the full confidence of the American people. A vaccine doesn't help if people don't choose to, in fact, be vaccinated. So my first question is, given that we've seen very high rates of both vaccine refusal as well as skepticism, what role can the FDA play in the coming months to earn the public's trust that the COVID-19 vaccines are safe and effective? That's question number one, what role the FDA can play. And then the second question is, what steps can you take as FDA commissioner to bolster public confidence?
Thank you, Senator, for that question. I couldn't agree more that public confidence in vaccines is so important. So to your first question, we have an obligation to use all of our scientific knowledge, our regulatory framework, to ensure that any vaccine that comes before us, whether for authorization or approval, meets our stringent standards for safety and effectiveness. One of the reasons that we issued that guidance that I mentioned in my opening statement was to provide regulatory clarity around what FDA expects with respect to those data. We want to see certain parts of those data so that we can demonstrate to the world, to the nation, to the American people, that we are following our rigorous standards with respect to safety and efficacy. The other thing that we've done is draw a very bright line between FDA and our regulatory independence and all the sponsors who are putting forth vaccine applications to us. and that includes Operation Warp Speed. So we are providing technical assistance to those sponsors, but we are not part of the decision-making process, and we will maintain our regulatory independence. I will not prejudge, the agency will not prejudge any decision with respect to this, but we will use the science and the data. With respect to what I can do personally, Senator, I commit to you that I will continue to be a voice emphasizing the regulatory independence. We have a number of communications in progress to communicate to the American people that the standards we're going to uphold are firm, they are rooted in science and data, and that they will ensure that we meet the usual high standards of FDA with respect to safety and efficacy.
Thanks very much, Doctor. I might submit a question for the record to Dr. Redfield as well, but just so I can get my second question in to the Admiral. Admiral, I want to ask you about testing and insurance coverage. Testing, as you know, and as we've emphasized in these hearings, is so fundamental in order to prevent the spread of COVID-19. Congress, I think, acted upon that knowledge by mandating full coverage of COVID-19 diagnostic and antibody testing, both in the Families First bill as well as the CARES Act. We made it clear that Americans shouldn't have to pay a dime for COVID-19 testing. But we're hearing alarming reports of people not being tested often for one of two reasons, because they're under the impression they will have to pay for testing, and patients who have been tested are receiving surprise medical bills. The administration has issued guidance that appears to be in conflict with congressional intent and public health guidance, and so we have some confusion here. I'd ask you, Admiral, can you assure the American people that the Department of Health and Human Services will fulfill the intent of both the Families First bill and the CARES Act and ensure that the American people will be provided wide access to COVID-19 tests without cost or limitation?
So thank you, Senator, and I want to thank all of you for emphasizing the importance of testing and eliminating any barriers that there could be. I can't speak for the department. I certainly speak as the Assistant Secretary and as the testing person that we firmly believe and support the concept of no-cost testing. There should not be a disincentive in any single way to get the diagnostic test that you need, to get tested during screening or the serology test as Congress intended. So thank you for that. We do need to keep getting that message out. It's a very important one to have.
Thank you, Admiral. Thank you, Mr. Chairman.
Thank you, Senator Casey. Senator Collins.
Thank you very much, Mr. Chairman. And I want to thank all of our witnesses today for your dedication and hard work. It's really been important. The chairman raised a very important question about who pays for the testing when a person has no symptoms and no known exposure to the virus. And I would add another key question, and that is, how are such tests even accessed? These are critical questions for the reopening of schools and for the thousands of jobs in the tourism industry upon which Maine's economy depends. In Maine, for a tourist to come and visit, that out-of-state visitor, one option is to show a recent negative COVID test. The problem is that when hotel owners in Maine surveyed testing sites in 10 states, they found that 90% of requests for a test for travel purposes were denied. Now, this lack of access to tests is devastating for reopening Maine's tourism businesses. One innkeeper told me that last year in the month of June, she had an occupancy rate of 94%. This year, it was 6%. So you can imagine the impact on employment at that inn. Given the impact on reopening schools and on jobs in the tourism and other industries, how is the federal government working with states to better match demand for testing with supply and to overcome these geographic variations? Admiral, I would direct that question to you.
So thank you, ma'am. I will try to be brief and not to take much of your time, but we were very careful in our prioritization that we do prioritize persons without symptoms who are prioritized by health departments or clinicians for any reason, including public health monitoring, surveillance, or screening of other asymptomatic individuals according to state and local plans. So that is a priority that if it is important for the state, those asymptomatic individuals can be screened. The second issue, just again to be brief, is we have worked individually with every single state. How are they organizing in the context of the CDC? And we are supplying them with the supplies they need to meet that. So every week, shipments of the basic supplies go to every single state according to their state testing plans. And we keep a little bit in reserve, right? Because when there's an outbreak somewhere that we need to surge, we do have that. So for example, the state testing goals for July are somewhere across the country, about 13.9 million tests is their first line goals, and we will match those state by state.
I hope that you will help us get that word out to testing sites in states from which a lot of tourists usually come to Maine. That would be very helpful to us. Dr. Fauci, let me turn to you. Earlier this month, higher education leaders in Maine issued a framework for safely returning to campuses this fall that recognizes the importance of testing and the need to include financially struggling institutions in partnerships in order to make sufficient testing protocols possible. You last week spoke about the possibility of the development of pool testing strategies. And as I understand this would allow more people to be tested using fewer resources. And the medical director of Stanford's clinical virology lab suggests that this makes particular sense in areas with low rates of COVID-19, where you would expect the large majority of tests to be negative. Could you expand on the possibility of expanding pool testing and tell us more about that?
Yes, thank you for the question, Senator. What that really is, if you want to get a feel for the penetrance of infection in a community, rather than testing each individual person, which takes resources and time, what you do, and you can do a statistical analysis of not losing sensitivity by pooling, let's say 10 or 15 or 5 together. So you put all the tests together and you do one test. If that test is negative, then you know those 10 people are all negative. So instead of utilizing 10 tests, you've utilized one test. Then you get another batch of, we'll say, 10 or so. And if you then find one is positive, then you go backtrack and figure out who that person is. And if you do the mathematical calculation, you can save a lot of time, a lot of resources, and use the testing for a variety of other things that you would need. So it's a really good tool. It can be used in any of a number of circumstances, at the community level or even in school if you wanted to do that. So apropos of what you started your comment off with, it clearly can be extrapolated to that.
Thank you so much. That sounds like an excellent technique for our schools to use.
Thank you, Senator Collins. Senator Baldwin.
Thank you, Mr. Chairman. I want to thank all of our witnesses today for joining us. Like so many members of this committee, I'm concerned about new outbreaks and increasing cases. Certainly, I've seen them in my home state of Wisconsin, and I know we're seeing that nationally. Now, CDC and Osha have issued recommended safety guidance for businesses, but this guidance is not enforceable. Many businesses are truly trying to do the right thing and protecting workers and customers and the public that interacts with those businesses. And so we also had a previous discussion. I think Senator Sanders raised the issue of American Airlines filling up their planes versus others that are still not trying to push to do so because of safety concerns. We also had, I think it was Admiral Girard, hold up the what he called critical guidance. Please follow this critical guidance. So, Dr. Redfield, should we be supporting businesses that have taken the steps to protect their workers and customers by fully implementing CDC's and OSHA's recommended safety guidance? Yes or no?
Yes, we should be supporting those businesses.
Now, can you confirm, yes or no, that all businesses have adopted and implemented this guidance as they've opened up?
I think, Senator, you know that unfortunately that's not been the case.
So it's an uneven playing field, and it hurts businesses that are trying to do the right thing by voluntarily adopting CDC and OSHA safety guidelines because their competitors don't have to incur the same safety and health costs. And if you believe that we should be supporting the good actors, then shouldn't we create a level playing field by issuing an emergency temporary standard to require all businesses to adopt and comply with enforceable safety standards?
Let me make two comments, Senator. First one is so important that we've tried to say is that this is a time that everyone in our nation accept the responsibility that Dr. Fauci and I spoke about, to recognize they have the fundamental responsibility not just to protect themselves, to protect others by the social distancing, face mask, and hand washing. Secondly, again, as we look at the local jurisdictions, again, to see where in fact that enforceability would be, whether it's in the local health department, the state health department, or the federal health department, I think, again, we see that the community can get behind that responsibility. Those businesses that support that responsibility may find, in fact, their business is better than those businesses that don't. I can tell you that
I want to interrupt you. I apologize, Dr. Redfield, but my time is limited. The panel right now is composed of people representing public health and public health institutions. OSHA is our lead federal agency for protecting worker safety and health. Have you had communication with the Department of Labor and OSHA about issuing mandatory enforceable standards rather than this voluntary guidance?
Secretary Scalia is a member of the task force, and he's in the discussions with us that the Vice President chairs. That specific topic,
yes?
we have not had a discussion directly, but we have had discussions and review of the guidance that we put to businesses, both critical infrastructure and non-critical infrastructure businesses, with OSHA.
I have limited time left, but I do want to say that the University of Wisconsin announced that they will be reopening for classes in the fall. They've released a plan called Smart Restart. It calls for about 2,000 tests per week on campus. They'll need supplies to do this, including PPE, reagents, and swabs. At every hearing on COVID-19, we've heard about shortages of these supplies. And it's why I introduced the Medical Supply Transparency and Delivery Act to unlock the full authority of the Defense Production Act to increase production of critical supplies, the things that are needed to conduct widespread testing. Admiral Giroir, can you describe how you're working to make sure that universities and others will have access to these supplies needed to conduct this testing in the fall?
So thank you so much, Senator. And I want to communicate this, and I'm happy to work with any university We coordinate what we give to the states through the state plan. So it's very important that universities coordinate through the states, and we supply those materials directly to a single point of contact in the state who distributes them. We've been through a lot, but we have a lot of swabs now, partially because of increased domestic production using the DPA. We're distributing about 20 million swabs per month. We're going to do a lot more than that.
How about reagents?
So reagents, we do not purchase centrally because the market is a little bit more mature, so we can trust with an allocation strategy that we support the allocation to different states depending on their needs. So we've mapped every single machine in every single state, every single county, every single city. And unfortunately, there's not enough of one thing that everybody, if they want that, can get it. So we really do a matching game to understand specific state needs. For example, in Alaska, it is very rural and there's very limitations to what they have. So we need to make sure they get what they absolutely need versus other states that can be a little bit more flexible. So we do have this control.
Thank you very much.
Yes.
Senator Ball, I'm afraid
I'm so sorry.
well over time. We have a large number of senators who want to ask questions, so I would renew my
Mr. Chair.
request that senators and witnesses try to keep the questions and answers within 5 minutes. Senator Cassidy.
Hey, thank you, gentlemen, for all that you're doing. I have a couple slides. Can I ask the staff to show the first two slides? So here it shows that we're doing poorly relative to the countries that are doing it best. And you can argue that Taiwan is much smaller than we, but Taipei is a very congested city. So if you consider our cities just a collection of Taipei's, for example, then our Seoul, South Korea's, it would suggest that what we are currently doing is less robust and less, whatever adjective you want to use, than the countries that are doing it best. Could I have the next slide, please? And so this is developed out of a group by Harvard, and just so I can put a plug in it, they will be speaking in a roundtable we have Thursday morning, and you can get details from my office if you wish. But kind of that interplay between collecting, doing the testing, tracing those, compiling your data, knowing where your hotspots are, and then tracing. And everyone on this panel knows this is how it's done. And you mentioned that you're going to have a strategy that's coming out later on. It does beg the question, why has it been so long? And I'm not accusing, I'm just curious. But this has been developed. You can take the slide down, please. So knowing that you're going to develop this strategy and kind of build upon what Senator Burr mentioned, what is the goal of the strategy? Is the goal of the strategy to achieve suppression? That's number one. And number two, what metrics will you use? And knowing that CDC is the one who really gives guidance to state and local governments, I'm hoping, Dr. Redfield, since I'll direct this to you, that it won't be up for the states and locals to put this plan together, but it'll be the considerable intellectual firepower of the CDC that gives a pretty detailed, if you have this kind of community, this is what you do. If you have that kind of community, that is what you do, because that's the kind of role that CDC is expected to play. Dr. Redfield, any thoughts on this?
Thank you very much, Senator. A very important question. First, on your first slide, just as a quick comment, and I'll try to be quick, I think it's really important because it does illustrate back to the comment that we tried to make of the importance of personal responsibility to really practice the social distancing. And
that is a given, Dr. Redfield. I'm going to ask you just to go quickly because I have limited time. That's a given. But there has to be a testing aspect of this because people don't, you awaken people to their responsibility if they know they've been exposed. If they don't know they've been exposed, they tend to be more complacent. So please focus upon the testing data and tracking aspect of it.
Yes, Senator. Initially, obviously, was early case identification, contact tracing, isolation. Obviously, testing and contact tracing without isolation has little value. The challenge has been when we learned in March that this virus is significantly asymptomatically transmissible, then therefore requiring alternative strategies. The strategy that we're evaluating now is more of a community-led testing strategy where you go into a broader community and you actually test a wide number of individuals as opposed
So
to...
do you have, what metrics are you following, and is there a specific strategy that's going to be given to state and locals as how to implement this? That's very high level. What we need is granularity. That's my question.
Yeah, we did the initial strategy, and as I said, we're currently evaluating this community test-led strategy in a number of communities now. The metrics are simple. It's the percent cases that are positive. We were doing well there for a while, you know.
May I ask, again, sorry to interrupt, but of course, if you take the entire city of New Orleans or Shreveport, you're going to have some that are hotspots and some that are really fairly safe. And so I'm pointing to the granularity. You know, should it be a census tract? Should it be a hotspot, a building with multifamily housing, et cetera? I guess I'm just frustrated because when I speak to my state and locals, they're not getting that granularity from CDC. That seems to be where we get to where Seoul, South Korea is. And I've not yet heard that is kind of what we're doing.
We're sharing right now at the county level the exact kinetics. We have about 130 counties in this country out of the more than 5,000, more than 3,000 are having trouble. And continuing to get that granularity, I think you've said it, Senator, it's critical. It's got to be a very local, focal response at the granular level.
But Dr. Redfield, do we have that granularity? We've been at this for 3 months. We've got all these data systems. We know where the people live who are tested. You know, we have a federated system, which you alluded to earlier. Is the plan coming out tonight, this afternoon, going to implement that granularity? I'm over time, but if you would allow, Mr. Chairman, for an answer, then I'll cease. I apologize for going over.
Yeah, my comment would be that's where we're going with that granularity. We appreciate some of the changes in reporting to CDC in terms of testing that Congress recently did. We are now looking at the granular